Welcome to Surge Hack Lectures. Today's topic will be cholecystitis. Cholecystitis simply means the inflammation of the gallbladder. Remember, itis in Latin means inflammation. However, before we proceed deep into this topic, we will have a brief overview of the biliary tree. So this is the biliary tree. Let's imagine that the liver is somewhere here. Let's imagine that this is the liver. So these are called intrahepatic bile ducts. So intrahepatic ducts. Intrahepatic ducts. And it goes down, fuses, and forms one channel. And this is called the common hepatic duct. And it goes down here. We have a branch to the gallbladder. This duct is called the cystic duct, so CD. And it continues, and this is called the common bile duct. Here it fuses with the pancreatic duct. This is called the pancreatic duct. So pancreatic duct CD. And they fuse together, and at the ampulla of vata they open in the duodenum. This is the duodenum. So, having said that, let's just imagine, let's go over how bile is secreted. So bile is secreted in the liver. This is the liver. So when bile is secreted, it goes through these ducts, through these intrahepatic ducts, flows to the common hepatic duct, then bile goes to the gallbladder where it is stored. And during meal, the bile is secreted from the gallbladder to the common bile duct. And also here, pancreatic juices are coming. They fuse together in the duodenum to help in the digestion of food. So this is an overview of how bile is produced and the movement of bile through the biliary tree. This is very important because if we have the basic understanding of how bile flows, then we can correlate this with certain symptoms that patients will present when they will have any pathology regarding the biliary tree. So let's go back to cholecystitis. So cholecystitis means the inflammation of the gallbladder. So whenever the gallbladder is inflamed, it is called cholecystitis. Now that we've talked about the inflammation of the gallbladder, what can be the reason for this gallbladder to be inflamed? So briefly, let's talk about etiology. So this gallbladder can be inflamed for two major reasons. We have alcalculous reasons, so alcalculous and calculus. So this is without stone, and this is due to stones. In the clinical setting, the most common reason for gallbladder inflammation is gallstone. So calculus, in other words, we will put as gall, or gallbladder stones. So stones, which consist of pigments and cholesterol, sometimes they form in the gallbladder. So you have the presence of stone in the gallbladder. Mind you that there can be presence of stones in the gallbladder but without cholecystitis. This condition is called cholecystitis. So it means presence of stone in the gallbladder, but without inflammation. So gallbladder stones. And the major reason for alcalculous causes of cholecystitis is you have tumors. And if we will go more specifically, these tumors can arise either from the liver itself. So the liver, tumors can arise from the liver, and tumors can arise from the gallbladder itself. So gallbladder tumors, and tumor can arise also at the head of the pancreas. So the pancreas is somewhere here. Let us add the pancreas to this photo. So this is the pancreas. Oftentimes you will see cases where there is tumor of the head of the pancreas. So tumor of the head of the pancreas. So this tumor compresses the biliary tree. As a result, it causes increase in pressure and it can lead to the inflammation of the gallbladder. However, put in mind that the tumor of the gallbladder is quite rare, but quite often, very common, we have tumor of the head of pancreas. So these are the three major causes of alcalculous cholecystitis. Of course, there are other cases like in immunocompromised patients, burn, and so on and so forth, or patients who are undergoing chemotherapy. However, these are the most common. Now we will talk about the pathogenesis of cholecystitis. So our stone. So the pathogenesis or pathology. I will put pathology for short. So what happens? When you have the presence of stones in the gallbladder, these stones might dislodge and block the cystic duct. So when this duct is blocked, what happens is there is build up in pressure in the gallbladder. So pressure increases here. So stones will lead to obstruction. This obstruction would lead to increase in pressure. Constant increase in pressure would lead to inflammation. So increase in pressure would lead to inflammation. So this is an overview of the pathology. So when there's an inflammation, these patients will now present with signs and symptoms. And the signs and symptoms that these patients present will vary depending on the severity of this inflammation. So now we will talk about the signs and symptoms associated with cholecystitis. So signs and symptoms. Just imagine if there's an inflammation, there's an obstruction and inflammation, what will be the first complaint the patient will have? It will be pain. And where will this pain be localized? If you understand your topographic anatomy, where the liver and the biliary tree are located in the gallbladder, is your right upper quadrant. So the pain will be a right upper quadrant pain. So we'll put right upper quadrant pain. And this pain can be associated with the intake of meals. So this patient will tell you that this pain is aggravated by intake of meals, especially food that have high fatty content. So maybe after barbecue, so high fatty food. This is because the bile is needed for the emulsification of fats. So when these patients have like high fatty food, they complain about this pain, it gets worse. And this pain is best described as biliary or biliary, depending on how you pronounce that, colic. It's a severe pain, and sometimes these patients might even feel they're having some like heart attack or something of that nature. Sometimes this pain might even irradiate to the scapular region. And that's what you have to remember. So pain. But again, this is a classical signs and symptom, because this pain might also be a peritonitis kind of pain. This is in the case of complications. So classically, the patient will complain about pain. What complaints can this patient present again? Next will be fever. So increase in body temperature. This might be subfebrile or febrile. It depends on the severity of inflammation. The next, this patient might complain of nausea and vomiting. Nausea and vomiting. So additional signs and symptoms that you may need to look out for is jaundice. Jaundice or icterus. So jaundice is the yellowing of the skin and then the mucous membrane. So if your patient is a fair skin patient, you have to look at the skin. If your patient has a dark skin, you have to look at the sclera. So you have to look at the patient's sclera to notice jaundice. Each of these will give you a link or a clue to where the problem is possibly coming from. So if the patient presents with jaundice and signs of cholecystitis, it probably means that this patient has this stone not just in the cystic duct, but in the common bile duct, somewhere here. However, this will be discussed in a consequent time. Now we will talk about how to diagnose cholecystitis. So, diagnosis of cholecystitis. Our first approach will be to have good anamnesis. This will help us to authentify our diagnosis and also rule out other pathologies. You have to pay close attention to these 5 F's whenever taking anamnesis from a patient suspected of cholecystitis. The first stands for female, so female patient. The second F is who is fertile. The third is fat. The fourth is fair. And the fifth is either 40 or 50. So these patients are at high risk of developing cholecystitis. Also, you have to ask this patient if they have lost weight abruptly. So abrupt weight loss. For example, if the patient is on some weight loss pills, or patient had some surgeries like gastric bypass, thereby leading to an abrupt weight loss. So you have to ask about abrupt weight loss. So when you exclude this, you can proceed to your physical examination. So anamnesis, pay close attention to those factors mentioned, in addition to the other aspects of it. And the second is physical examination. So physical examination. Patients with cholecystitis, usually we talked about the kind of pain they have, the localization of pain, and the character of the pain. So during your physical examination, you have to pay attention to this sign. It is called Murphy's sign. Murphy's sign. And what is Murphy's sign? Murphy's sign is when the patient is lying supine and you place your fingertips at the right costal margin, mid-clavicular line. You place the tips of your fingers on this patient's abdomen. So let's imagine that this is the costal arch from the right and this is from the left. So you place your fingers, the tip of your fingers, ask this patient to breathe out, and then ask this patient to breathe in, to inspire. At the height of inspiration, this patient's inspiration is interrupted. They interrupt the inspiration because of pain. And that is positive Murphy's sign. Physiologically, what happens is, during this inspiration, there is a contact with the gallbladder and the tip of your finger, and this causes an irritation and the pain becomes more pronounced. So it's positive Murphy's sign. You have to look out for this. In exams, usually this pain is described but without the name. So if you can understand this pain, then you understand they're talking about Murphy's, and with Murphy's, you know they're talking about cholecystitis. So number 3, after your physical examination, number 3, we have to talk about the lab exams. So lab examination. And for your laboratory examination, we'll talk about the CBC, which is the complete blood count, and liver biochemistry, biochem. In the complete blood count, what are you looking out for? You are looking out for increase in leukocytes and white blood cells, that is leukocytosis. You're looking out for increase in C-reactive protein, one of the indicators for inflammation, and probably the erythrocyte sedimentation rate, ESR. These are things that you're looking out for. However, your blood film might be different. You may have more, less, or slightly increased white blood cells. But look out for this when you're looking out for cholecystitis. And in your liver biochemistry, for patients with cholecystitis, we are very concerned about bilirubin. So bilirubin, we have the total bilirubin, we have the direct bilirubin, and the indirect. Although increase in bilirubin is not typically characteristic of cholecystitis, however, sometimes you may see the increase of bilirubin. And when you see the increase of bilirubin, you can predict or assume that probably this stone is not just in the cystic duct, maybe it's somewhere else. So you have to look at the patient's bilirubin. The next fragment of this liver biochemistry that is important is liver enzymes. Liver enzymes. What are these enzymes? You have number 1, alanine transaminase, abbreviated as ALT. The second one is aspartate transaminases, AST, and the third one is alkaline phosphatase, abbreviated as ASP. Why are these enzymes important? If you have a significant increase in ASP, that indicates the presence of stone or the obstruction of the common bile duct. So it can be due to the stone, or it can be due to a tumor or other causes. So a significant increase in ASP, will point at the obstruction here, not necessarily here. And ALT and AST, these are indicators of some problem in the liver, maybe hepatitis or something going on. But in the case of cholecystitis, you still have to take a close look at these liver enzymes and bilirubin level. So once you are done with the laboratory analysis, we will progress to imaging. Always have it at the back of your mind that in the clinical setting, we always try to start from the least invasive, the least traumatic, and the most economical diagnostic techniques. In the case of cholecystitis, we will start with ultrasound. So abdominal ultrasound. Abdominal ultrasound is easily and readily available in all hospitals. It is very specific for cholecystitis, and you will get the result in the least possible time, in a matter of minutes. So abdominal ultrasound, what are you going to look out for in abdominal ultrasound? Of course, you see the presence of stones in the gallbladder. They usually cast a shadow, and you will see that the dilation of the gallbladder wall. So usually it's dilated more than 3 millimeters. And if you remember from the signs and symptoms we discussed earlier and the pathophysiology of cholecystitis, we talked about inflammation. And one of the signs of inflammation is edema. So in ultrasound, you will see fluid around the wall of the gallbladder, and this is called the pericholecystic fluid. Once this is seen, you don't really need to progress to other forms of imaging. Given your labs, you can actually start your treatment from this point. However, you can also add a CT scan, maybe to rule out other pathology. But once you see these two things or these signs with the ultrasound, there's really no need to progress to CT scan. Now we will talk about treatment. So how do we solve this problem? How do we treat patients with cholecystitis? This again depends on the severity. It depends on the severity. So if the patient comes with uncomplicated case, the treatment approach is different. However, we will talk about the classical treatment of non-complicated cholecystitis. You have to stabilize these patients first before you think about surgery. So stabilizing these patients involves telling them not to eat anything, so nail per os, so that the pain will not get worse. The second approach is to give this patient painkillers like morphine and atropine to relax the muscles and take away spasm. And you should rehydrate these patients because sometimes because they cannot eat or because they feel pain when they eat, they refuse to eat at all or even refuse to drink water. So you can rehydrate these patients by giving them, if they can drink water, tell them to drink water. If they can't drink water, you can start by giving them maybe 5% of sodium chloride. So that's Renga solution. You can give them Renga solution IV. Once this patient is stabilized, you can now think about surgery. You can now progress to surgery. So here we'll talk about stabilize. So stabilize the patient. And now we'll talk about surgery. So surgery. This patient is ready to be taken to surgery. And what do we do in surgery? We do cholecystectomy. Cholecystectomy means the removal of the gallbladder. So what do we do in surgery? This can be done with open surgery, but now laparoscopic surgery is the gold standard. So it can be done with laparoscopic surgery. So you go into the patient's abdomen, you ligate the cystic duct. Of course, remember it has vessels like cystic artery. You also ligate the cystic artery, and that is it. So you've performed cholecystectomy. And yes, these patients can live their normal lives without the gallbladder. So once cholecystectomy is performed, these patients can go home in 2 days. Now we will talk about the complications of cholecystitis. These are things neither you nor the patient wants. However, things happen. So the first complication is empyema. Empyema. This simply means the formation of pus. So pus can be formed all around the gallbladder. So it's empyema. And you understand why increase in pressure, increase in inflammation, and if it's left untreated, it can lead to infection, and then you have pus formation. So pus formation. The second complication is gangrene. So if you remember from your pathology, gangrene is a form of necrosis. So it's the death of the gallbladder. So the necrosis of the gallbladder, because there is no longer blood supply and drainage, venous drainage from the gallbladder. So the gallbladder tissue dies. So that can be gangrene. Next complication is the perforation of the gallbladder. So we write perforation or rupture of the gallbladder. What does this mean? If the patient is unlucky and this inflammation continues and nothing is done, the build-up in pressure and the death of the viable gallbladder tissue will make the gallbladder wall weak and can lead to the perforation or rupture of this gallbladder. And what happens is that the contents will flow into the abdominal cavity. And once this happens, it can lead to either abscess formation or peritonitis. The next complication is called a fistula formation. Fistula formation. And how does this happen? When there's inflammation, inflammation also leads to the adhesion of adjacent structures. So it might lead to the adhesion of within the gallbladder and the duodenum or the biliary tree. So the common bile duct, for example. And also the large intestine, which it's somewhere there. So these adhesions might lead to an abdominal fistula formation. So it's an abdominal connection between two organs. So now the gallbladder is connected to the duodenum. It's called a fistula formation. And what happens once this occurs, the stone or stones from the gallbladder will migrate to the duodenum, and of course to the small intestine. It continues, the stones travel, and they will cause obstruction, especially at the ileocecal valve. So that is where the ileum enters the colon, the large intestine. So somewhere here at the ileocecal valve. So somewhere here, the stones get stuck. So once this stone gets stuck here, we have what we call gallstone ileus. Gallstone ileus. And this will lead to the intestinal obstruction. So the intestine will be obstructed and it will present with a different clinical picture, like distension of the abdomen and vomiting. So these are the complications that you can expect from a patient who has cholecystitis.